All right, so this is the thorax axilla breast exam. I've already washed my hands prior to the exam. This is the patient. I'm introducing myself. Hi, my name is Shana Mitchell. I'll be your nurse practitioner for the evening. So first, we want to assess our patient since he is a male. Look for any nodules in the chest area, if there were any swelling, ulcerations, or gynecomastia. The patient is seated in a supine position. We would palpate the areolas for the breast nodules and palpate to distinguish any glandular enlargement from any soft fat enlargement of obesity. We would inspect the axilla in both males or in females. We would inspect for things such as rashes, lesions, masses, or pigmentation. We would palpate the patient's lymph nodes. So using a slightly cupped hand, place tops of the fingers of the apex of the axilla and then point down mid-clavicular, press inward against the chest wall and slide hands down. We would use our left hand to examine the right axilla and examine in the same direction towards the mid-clavicle area and then press inwards against the chest wall. We would palpate the pectoral lymph nodes by grasping the anterior axillary fold between the thumb and the forefingers. And from that, we would hold between the thumb and the fingers and palpate inside the border of the pectoral muscle. As far as the thorax area is concerned, we've already taken our patient's blood pressure. We would percuss and resonate sounds over our lung fields. So I'm going to assess the patient's lung sounds. We're going to ask the patient to take a deep breath. Go ahead and take a deep breath. And another. And another. The apex of the heart, and another. And we're going to have the patient lean forward so we can also have the patient take another deep breath. Again. 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 And again. The patient's lung sounds are clear to auscultation. There is no wheezing heard or any crackles or rhonchi throughout the percussion of the lung fields. We have already palpated our axillary lymph nodes. There's no palpable lymphadenopathy noted in the axillary regions. Patient has a normal thorax, lungs, and axilla upon examination. Other things we would do to assess patients when we are talking about the breast exam and performing a physical assessment is that we would also discuss having to have the patient discuss their job requirements, such as like the certain occupations, any history of asthma or anything, so that way we can rule out any potential differential diagnoses such as acute respiratory infections like pneumonia, bronchitis, chronic respiratory infections such as COPD or asthma. We would want to assess for any pulmonary embolism, pleural effusion, or any cardiac conditions. Again, another big major area that we would assess for is breast cancer or musculoskeletal chest pains. Sometimes people with somatic symptoms have reported areas of anxiety. So we would rule that out to make sure that we would not induce a panic attack for the patient. Additionally, when we are doing our inspection, especially of the respiratory system, we want to make sure that when we're palpating areas, that if the patient reports pain in some of the areas where a lesion or a bruise may be evident, we would use one or both hands depending on the patient's history. We would look for the chest expansion if it's symmetrical or asymmetrical, any diaphragmatic breathing, or any exertional breath such as dyspneic on exertion, and assess for any tactile fremitus or popping sound. We would use the ulnar side of our hand with both hands at the same time at the apex side and move down the level of the xiphoid process, mid-clavicular line, stopping at just above the breast and starting under the breast. We would ask the patient to cross their arms, and we would start at the apex and move along the medial scapular border to the level of the 10th rib, then move laterally on each side using an appropriate diphthong. So that is how we would do our palpation assessment. For our percussion, again, both sides need to see if there are posterior, lateral, or anterior using proper locations and sequence. If posterior, we would ask the patient to cross their arms in front at the apex, such as the patient is doing now. Again, move along the medial scapular border to a level of the 10th rib. Another area that we would look for is auscultation. So when we were assessing the patient's lung sounds using our stethoscope, we did not hear any ladder patterns or any congestion or any wet sounds in the lungs. The patient was able to take deep breaths through opening his mouth without any issues. And we were listening for the patient's pitch, intensity, and the duration of his expiration and inspiratory sounds. When we perform a voice transmission test, if that's indicated, we are further suspecting consolidation like bronchophony or egophony or any whispered pectotriloquy. We would use the same osculatory steps that we did in before, and we would have the patient say Scooby-Doo.
Scooby-Doo.
So the patient has not changed from any sounds, but we will show a visual presentation of the demonstration. Say that again.
Scooby-Doo.
Again.
Scooby-Doo.
Again.
Scooby-Doo.
Again.
Scooby-Doo.
Okay. So we've completed the breast and respiratory examination of the patient. Other areas of the examination we can look for such things as including doing a mental assessment. Sometimes some patients might have a referred pain area due to what they've discussed. As far as anxiety or panic disorder with, like as previously stated before, with somatic symptoms, or any cardiac conditions such as pericarditis. Specifically, we would ask, if the patient has been to the dentist lately to rule those things out, endocarditis, or any heart failure of the patient. When we took the patient's vital signs earlier, the patient's blood pressure was within normal limits. It was 120/80. His pulse was 70 beats per minute. His respirations was 16, and his temperature was 98.6. The patient appears comfortable. You can lower your arms. And no acute distress, no tenderness, crepitus, or palpable masses detected upon palpation of the thorax and axilla. Again, we resonated with percussion and heard over the patient's lung sounds, starting going in a Z-type formation. And additionally, we also heard breath sounds without wheezing, crackles, or bronchi. Again, this patient in particular in front of me does have a normal thorax, lungs, and axilla examination. And there is no lymphadenopathy detected or no benign breast conditions or cardiac conditions. This concludes the end of the exam.